Foot complications are the most common reason for admitting a patient with diabetes to hospital and are the most costly of all the diabetic problems. This video is intended to provide the essential information for those involved in assessing the diabetic foot. We'll be showing you basic vascular assessments using a handheld Doppler and how this method could be used for more advanced measurements. We'll also be demonstrating methods for detecting neuropathy using a monofilament and other techniques. The prevalence of diabetes across Europe is between 2 and 6% of the population, and worldwide is expected to double over the next 10 years. For a large hospital serving an average population of 300,000, at any one time 200 people will have a foot ulcer, and in 1 year between 30 and 50 of these will go on to amputation. UK studies have estimated that the cost of managing a diabetic foot ulcer is £3,600 a year, and the cost of a single major amputation is approximately £15,000. It's been shown that by establishing a multidisciplinary foot service and regular screening and education, amputations can be reduced by up to 50%. There are many of us in the healthcare team who are involved in looking at patients' feet. So what should we be looking for when screening? The foot that we're now examining is normal. Notice the colour. There's no deformity. The nails look healthy. There's normal hair growth and the skin looks in a very healthy condition. There's no callus and no evidence of fungal infection. The patient has normal sensation and can therefore feel all neurological tests. Normal Doppler signals can be heard and are typically triphasic in nature. The most common complication that you're likely to find on screening is peripheral neuropathy, which can result in total loss of sensation in the feet. This can be really dramatic. For example, you may see a patient who has a nail through their foot that they are unable to feel, or who has been burnt from falling asleep in front of a fire. The neuropathic foot looks pink and healthy, but we can see that there is some deformity. Notice the clawing of the lesser toes and the increase in the arch of the foot. There's generalized dryness and some callus formation, particularly on weight-bearing areas. The deformed foot gives rise to areas of high pressure, which may directly cause injury or trauma from poorly fitted footwear. We are going to demonstrate a few of the tools that are most commonly used.
And finally, back on the hand.
We should explain to the patient what we're going to do.
Can you feel that?
Begin by testing on a sensitive skin surface. Now carry out these tests on the patient's foot at various sites, avoiding any calloused skin areas. We ask the patient to close their eyes and say yes every time they feel something. We strongly recommend the use of the 10-gram nylon monofilament as it's the most objective, reliable and reproducible tool for testing light touch. The monofilament is placed at 90 degrees to the skin surface, pressed gently until the filament buckles, held in this position for 2 seconds, and then removed. Do not let the monofilament wriggle. Less reliable methods for light touch are cotton wool or your finger. Obviously, when you feel the patient's skin, they should be able to feel you. Here you can see sharp sensation being tested. We advise that pins should never be used as they easily breach the skin surface and can cause a wound. We recommend the use of a neurotip. Vibration perception will now be tested using a tuning fork. The limbs of the tuning fork are squeezed together, quickly released,
Feel it vibrating?
and then placed over the big toe. The patient describes what they feel, such as pressure,
No, not quite.
cold sensation, or vibration. It is important to recognize that vibration perception can decrease with age. A patella hammer may be used to test for motor function, but tells us little of loss of protective sensation, which is more important.
That's it.
If only one test is to be chosen to screen for peripheral neuropathy, we would strongly recommend the use of the 10-gram monofilament. The pulses in the neuropathic foot are usually strong and bounding due to autonomic dysfunction. The arteries are vasodilated and have a characteristic Doppler signal and waveform. Compare this with a normal sound and waveform. The neuroischemic foot is characterized by the presence of neuropathy and ischemia. Frequently there is patchy sensation loss, and the foot pulses are weak and typically monophasic with a low pitch. A complication that you may see is peripheral vascular disease. All of our arteries, whether we're healthy or otherwise, tend to fur up with age. However, in a patient with diabetes, atherosclerosis is more aggressive, affecting the vessels in the lower leg, namely the popliteal, the peroneal, the anterior and posterior tibial arteries. This results in diminished or absent foot pulses. Here, a handheld Doppler is very useful. The ischemic foot looks thin. The skin is pale. There's a loss of hair, and the nails are dystrophic. If there is hard skin present, it'll be very thin and glassy in appearance. To assess whether or not a patient has adequate blood flow, you should always feel for the foot pulses, then use a Doppler. So let's have a brief reminder of where the arteries are located on a patient's foot. Firstly, the dorsalis pedis, which arises from the anterior tibial artery that runs down the front of the leg. Here you can see, drawn on the patient's skin, where you should be able to detect the dorsalis pedis pulse. The second pulse site is the posterior tibial artery, and, as the name suggests, it's located just behind the tibia bone. Here again you can see marked on the patient's skin the area where you should be able to detect the posterior tibial pulse. You may find that occasionally you cannot feel a pulse, but the foot looks healthy, well perfused, and feels warm to the touch. This may be due to the arteries being situated very deeply, or in a different position to normal, or due to the presence of edema. A useful tip is that if you cannot find the dorsalis pedis pulse at its usual site, try the base of the first and second toe. The use of a handheld Doppler can be invaluable in these situations, and we would stress that if you have a Doppler, it should be used routinely. This will give you more information than just feeling a pulse with your fingers. Now let's have a look at a handheld Doppler being used on a normal foot. The Doppler is able to detect moving red blood cells, and this information is conveyed in the production of an audible signal. It is also possible to link your handheld Doppler to a printer or a computer, and using a software package you can record Doppler waveforms and pressures. The waveforms obtained from these can be used as a permanent hard copy reference of your vascular assessment, or can be used as additional information when referring a patient to a vascular surgeon. The waveforms are fairly easy to interpret, remembering that the trace above the baseline represents forward flow and the trace below the baseline represents reverse flow when the probe is pointing towards the heart. Let's listen to that signal. You'll notice that it has a typical phasic characteristic. Now, in a normal, healthy person, the arterial signal is said to be tri- or biphasic, which means it has either 3 distinct beats or 2 distinct beats. Now let's go on and examine a patient with some arterial disease. Here you can see the Doppler probe being placed gently on the skin surface, with the probe facing towards the heart. And you'll also notice there is a generous amount of coupling medium, or gel. If a patient has some degree of arterial stenosis, then the Doppler signal is monophasic. Can you hear how different this is to the signal we've just heard in the normal foot? Let's listen to them both again. Here's the normal sound. Now here's the abnormal sound. Another test that we can perform is the ankle brachial pressure index. Using the Doppler, take the brachial systolic pressure in both arms. Use the higher of the 2 readings in your calculations. If the readings are significantly different, this suggests arterial disease. Then the ankle systolic pressure is determined. The blood pressure cuff is placed around the leg, just above the ankle. The posterior tibial and dorsalis pedis pressures are measured, and the higher reading of the 2 is used to calculate the ABPI in that leg. If there is significant difference in pressures, arterial disease could be present. Having completed the examination, excess gel is wiped from the Doppler probe immediately after use, and the probe is cleaned with an alcohol-impregnated wipe to reduce the risk of cross-contamination. In this example, the ankle pressures for the right leg were 80 and 85, and the brachial pressures were 145 and 150. The ankle brachial pressure index is calculated by taking the higher ankle pressure reading of the 2 pulses in one leg, that is 85, and dividing it by the higher brachial pressure reading, in this case 150. The ABPI is therefore 0.57. Alternatively, an ABPI chart such as this could also be used. If the ABPI is between 1 and 1.3, the presence of arterial disease is unlikely. If the reading is between 0.8 and 1, some arterial disease may be present. If the ABPI is between 0.5 and 0.8, significant peripheral arterial disease is present. If it is less than 0.5, then severe arterial disease is present, requiring urgent attention. If the reading is greater than 1.3, arteries are calcified and non-compressible. Therefore, this test is not valid. If observations indicate ischemia, but this is not reflected in the ABPI measurement, suspect calcification. The Doppler signal is likely to be monophasic. Digital arteries are generally spared of calcification, so, if possible, toe pressures should be taken. By placing an appropriate sized toe cuff around the base of the big toe, and using the Doppler probe on the digital artery, a toe systolic pressure can be determined. If the toe pressure is less than 30 millimeters of mercury, the prognosis for healing is poor. If the pressure is greater than 50 millimeters of mercury, then ulcers have a good chance of healing. If the toe brachial pressure index is less than 0.64, then arterial disease is present. Another test that we'd like to show you is the pole test. We use this to determine whether a patient has poor blood flow in the presence of arterial calcification. and is useful when toe pressures cannot be measured. The pole test is undertaken by holding the Doppler probe over the vessel whilst elevating the leg from the horizontal position and listening to the arterial signal at the same time. If the pressure drops in the artery as we elevate the limb, the arterial signal will change or fade, indicating a compromised arterial circulation. If a graduated pole is available, the height at which the signal disappears can be used to estimate the ankle systolic pressure. The Berger's test, or the elevation and dependency test, is another clinical procedure that's useful in the diabetic. Here we place the patient's leg above the level of their heart and look for colour changes. Obviously, if there's very little pressure within the arterial system, the blood doesn't like flowing uphill, and therefore the leg becomes more pale or blanches. We then lower the leg so that it is below heart level, and once again we observe any colour changes. If the patient has poor blood flow, we'll notice that the foot and leg may well become a vivid red colour. This generally occurs from the toes and spreads up the foot and leg. If this happens, then the patient has quite marked arterial disease. We have shown you a brief examination of the diabetic foot, testing for peripheral neuropathy and vascular disease.
It's just to fill in your book.
It is important that we assess patients in a structured and standardized way and record our findings. It is equally important to explain to the patient what we're doing, as this will form a basis for good health education and a better patient-practitioner relationship. The basic foot examination should include a 10-gram monofilament and a Doppler examination. This should be carried out regularly on all diabetic patients. Toe pressures should be measured on patients with calcified arteries and Doppler waveforms recorded as part of a continuous patient assessment. This video showing a basic diabetic foot assessment should enable you to identify the at-risk foot. Remember, this is only the first step in prevention of foot ulcers and lower limb amputation.